session number 22, and it's on imaging and physiological assessment in intervention. As chairperson, we have Professor Fazila-Tun-Nesa Malik, Madam, Professor Mir Jamaluddin Sir, Professor Muhammad Shahabuddin Talukder, Professor M.J. Azam. As moderators, we have Dr. Iftekhar Alam, Dr. Smita Kanungo, and as a panelist, Professor Salauddin Ulubbi Sir, Professor Jahanara Arju, Dr. Khurshed Ahmed, Dr. Pradip Kumar Karmokar, Dr. Kajal Kumar Karmokar. As the speakers, we have Dr. Sanjog Karla, Professor Ms. Jamaluddin, Dr. Ajoy Dotto, Professor Chaudhary Meskat Ahmed Sir. I would like to request all the chairperson, moderators, and panelists to take their chair on the dais.
This session will deal with imaging and physiological assessment of the interventional studies. And I request the chairperson of this session to take their chair. It will be honored the chair by Professor Dr. Fazila-Tun-Nesa Malik, Professor Dr. Mir Jamaluddin, Professor Muhammad Shahabuddin Talukder, Professor M.J. Azam, and the panelists are Professor Salauddin Ulubbi, Professor Jahanara Arju, Dr. Khurshed Ahmed, Dr. Pradip Kumar Karmokar, and Dr. Kajal Kumar Karmokar. And I would like to also invite Professor Chaudhary Meskat Ahmed Sir to take his chair in the dais. First speaker is Dr. Sanjog Karla. Dr. Sanjog Karla will be speaking on how IVUS helps in optimizing the PCI.
Good afternoon, everyone. Thanks very much again for the opportunity to speak. Over the next few minutes, I think we'll talk a little bit about how to use a very versatile tool that can be used in many, many different ways in PCI to try to optimize results. So rather than focus on the various spheres that IVUS can be used in, because that's not a 10-minute talk, it's a 10-day symposium. Instead, we'll focus on just how to use IVUS for the fundamentals that we try to use. And maybe within that, I'll try to give you an approach that works for me to remember how to use IVUS to its highest capabilities when stenting. These are my disclosures. So there are many formulae to decide how well you've put in a stent, right? What we try to do is make stents as large as they can, but obviously we don't want to perforate the artery. We don't want to injure the patient. We don't want to dissect beyond the stented segments. So as a result, there isn't a whole lot of agreement around what the right way is, right? There's 14 formulae, some of them say 90% of the distal minimal lumen area, some say 80% of the distal minimal lumen area, some say normalized physiology, some say borderline physiology, who knows? And the fact that there are 14 of these things tells us something. Nobody agrees, right? So the general principle that we can use to follow is pick one formula, whichever one you want, but you're always aiming for the best expanded stent you can get, the biggest minimal stent area you can get, without having to injure the patient, without injuring the patient. So based on the European consensus document a couple of years ago, we aim for a minimal stent area that's 80% of the distal MLA and greater than 5 millimeters squared by IVUS and 4.5 millimeters squared by OCT in the proximal vasculature, okay? This is obviously not a reasonable target in a distal diagonal branch, but it certainly is in the proximal to mid-LAD. So here's an approach that I designed some years ago that's a little bit like the MLD max approach, okay? Only it fits with IVUS, okay? It's largely designed for this technology. And these are the questions that you ask yourself to answer. It's called the PEARLS approach, so IVUS PEARLS. P is the plaque composition. So what is it that you see? And while you're recognizing what you see, you're trying to plan how you're going to treat this. Is it calcium? Is it fibrotic plaque? Is it lipidic plaque, etc.? Is it thrombus? So what do you see? P is for plaque composition. E is for EEL to EEL diameter in the distal reference zone. So your adventitial to adventitial diameter, right? Your maximum vessel size at your distal landing zone. We try to land stents in as normal vessel as possible so that this can be an accurate representation of sizing. Right? There are obviously caveats because plaque grows in the media, so the vessel can look very large when in fact you don't necessarily want to measure right across all of that plaque. So try to find yourself a distal landing zone where you can see the EEL on one side and see the EEL on the other side and measure it. A is the arterial lesion length. So how long is your lesion? So on your IVUS pullback, as long as your guide is well engaged and it's not bouncing back and forth, the pullback measurement will actually give you a lesion length, and that's actually very useful information to plan your procedure. R is the reference vessel size proximally. So effectively your EEL to EEL at the proximal edge, where you're going to land your stent. And then L is your landing zone selection. Okay, so find a landing zone both proximally and distally that is as close to normal as it can be. Sometimes we can't do that. So if that's the case, then find a place with less than 30% plaque, because that's your most likely zone where you're going to get good stent expansion without an edge dissection, either on the proximal or distal ends. And then finally, S is your stent size selection. This is where the gold is, because a lot of times we don't remember that our stents have very clear confines in which they can be expanded and grown. And so selecting the wrong stent size or the wrong stenting strategy can leave you in a place where you're actually fracturing your proximal end. And that leads to terrible outcomes. One of the most potent risks of stent thrombosis or NIDI for restenosis is a stent fracture. So what are the general goals? Largest possible minimal stent area, avoid the risk of excess size, so excess ballooning, avoid gross malapposition. Acute malapposition is no big deal. And then aim to stent normal to normal. Okay, and the best way to determine the information you need for all of these things is by using IVUS, because what it will give you is the precise measurements at each of these areas as well as the plaque composition. So let's use the pearls example and this one example, and well, maybe we can make this interactive. I'll throw this out to the panel, anybody who wants to deal with this. So you've got a 14 millimeter lesion, you've got a 2.7 millimeter distal landing zone, you've got a 3.2 millimeter proximal landing zone with almost no plaque at either end. Okay? So having said that, maybe we can use the pearls approach to define a stent strategy for this lesion. Let's start with P, plaque composition. Let's say this is fibrotic plaque. We can make that up, right? So E is your EEL to EEL distally. That's 2.7. A is your arterial lesion length. That's 14 millimeters, right? R is your reference vessel size. So 3.2 millimeters, right? That's the proximal. L is your landing zone. Well, you picked your landing zones, right? You've got the 2.7 millimeter landing zone distally and 3.2 millimeters proximally, because on that L landing zone, you've picked areas with relatively minimal plaque, so almost normal to normal. And then S is your stent size selection. So this is easy, right? This is almost any stent on the market. You can take a 2.5 by 15 millimeter Xience stent, or a 2.5 by 16 millimeter Synergy stent, or pick one, right? It doesn't matter. Deploy it, and then you post-dilate using a 2.5 millimeter non-compliant balloon at high pressures at the distal end, and a 3.0 millimeter non-compliant balloon at the proximal end. The beauty with the IVUS is it can also show you where your branches are. And so you can line up, by fluoroscopically co-registering your IVUS, you can line up precisely where you want to post-dilate so that you don't oversize a segment of negative remodeling and you don't undersize a place where you actually need to expand your stent. So that's the Pearls approach in action, okay? And this is all of that stuff, right? This is all of the details that we just went through very intuitively. So you stent it with a 2.5, take it up with a 3.0. So let's try this second example. This is a long lesion now with some size disparity. You have a 3.0 balloon, you have a 3.0 distal landing zone, you have a 4.5 proximal landing zone as you've selected. So let's Pearls this again. Let's say once again this is fibrotic plaque or calcific plaque, doesn't matter. We're going to pick what we're going to pick to fix it. Then your EEL to EEL diameter distally is 3.0 millimeters. A was your arterial lesion length, so that's 36 millimeters, right? We've measured it using the IVUS. R is your reference vessel size, so proximally you're at 4.5 millimeters. L is your landing zone assessment. Are we satisfied with these landing zones? Is everybody happy with these? We've got a reasonably normal looking vessel where we're landing the stent. So now let's select a stent size. That's all of the information you need to figure out what stent you want to put in. So do we have a stent that can go from 3.0 to 4.5? Does that exist? Not really, right? The Synergy goes from 3.0 to 4.25. Resolute Onyx goes 3.0 to about the same. Your Xience Expedition 3.0 platform goes to 3.75. So this is a situation where you can use one of two strategies. You can either take a 3.5 millimeter stent, which is where the stent sizing platform changes, okay, and under deploy a 3.5 millimeter back to your landing zone, so under deploy it at 8 atmospheres. This is sort of what we discussed with Professor Mir Jamal while he was doing his live case. And then you can selectively post-dilate, leaving one strut from the distal end with a 3.0 millimeter balloon distally, a 3.5 in the middle, and a 4.0 to high pressures proximally. That'll take you to 4.2, 4.25. And that's pretty good. Another option is to take a short 3 millimeter stent and overlap it with a short 4 millimeter stent. So 2 18s, for example, or 120 and 118. Because then the 3.0 will easily go to 3.5, but your 4.0, which is capable of going to 5.75, will take a 4.5 non-compliant balloon at the proximal end, and that's truly the largest you can make it. Personally, I don't think there's an appreciable difference between 4.3 millimeters and 4.5 millimeters, so I would stick with the safer of the two strategies, to be honest. But it depends on where you are, right? If you're one strut outside of the left main and you really want to make that big and trumpet it, you may choose the second strategy. It's a very reasonable thing to do. So these are the details that you need to know, right? The devil is in the details, and this is an old chart. Don't use this. Find a new chart. I didn't have quick access to the newest charts, but these things have changed, right? Like the 4.0 millimeter synergy, for example, will go to 5.75, right? So, you know, the Resolute Onyxes will go up to 5.75 as well, right? Your Resolute Onyx goes, your Megatrons go all the way up to 6, right? So these are the details. These are the things you really do need to know, because this is what makes you good at PCI. This is, remember we talked about square peg into square hole, round peg into round hole. So this is about selecting just the right tool for what you need. So this is what, you know, we might choose to do in this sort of a scenario, because we know the expansion limits, right? Take a 3.0, put it to 4.25, or take a 3.5 all the way back and go up to 4.25 there. Okay? So what about example 3? So this is what your vessel looks like. So now you have a terrible vessel, right? You have a nice proximal landing zone, but you have an unhealthy looking distal landing zone. How do you manage this? It's the same way as everything else, right? There's no magic here. It's all very easy. P, standard lipidic plaque or standard soft plaque. So we balloon it open with a compliant balloon. It opens, you're ready to stent, right? EEL to EEL diameter. You can't really find a clear EEL in the middle of the lesion, right? So you have to move all the way out here. But going way out here means the vessel gets very small. So you have to select a landing zone that's got some disease in it. So EEL to EEL still remains your 2.75. But when you've got more than 30% at your landing zone, 30% plaque at your landing zone, now you're stenting plaque to plaque, okay? Because you don't want to dissect that plaque. So for a 2.75 landing zone that may be EEL to EEL, the plaque diameter might be 2.25. So then you're going to choose a 2.25 distal edge stent and then post-dilate everything but the last strut up so that you can maximize the size. Your goal is a minimal stent area that's 80% of the distal minimal lumen area, right? It's the same goal. And so if you're landing in disease, you've got to be careful when you land to ensure that you don't dissect that plaque. Even if you land conservatively with sizing at your distal strut, you can IVUS that, prove there's no dissection, and then post-dilate proximally aggressively. So going back to pearls, plaque we talked about, your distal EEL to EEL we talked about, A is your lesion length, right? So let's call this lesion length whatever you want to call it. 18 millimeters. Let's say it's 18, okay? R is your reference vessel size. So what do you think about the proximal landing zone? Proximal landing zone is nice, right? There's less than 30% plaque there. And that, once again, is what your IVUS is telling you. So you can IVUS that, prove that that's a healthy landing zone, and be very comfortable putting a 3.5 stent in. So R is your reference vessel size. L is your landing zone. So you've selected the distal one in disease because you don't really have a choice, right? You don't have a great place to put this stent. Proximally, you're much better off. Proximally, you've got a normal landing zone. So with your IVUS, you can very precisely select the stent that you want. What kind of stent would we want to put here? Let's say that instead of 2.75, it's 2.5 in the distal edge and 3.5 in the proximal edge. Now all you need is a 2.5 stent that's capable of going up to 3.5, right? So your media to media might be 2.75 or 2.95, but your lumen is 2.5. So you're going to select maybe a Resolute Onyx stent, right, where the 2.5 will go up to 3.5 without breaking a sweat. And then distally, you'll post-dilate with a 2.5 millimeter balloon, leaving the last strut behind, gradedly post-dilate through the stent, and then take a big 3.5 millimeter balloon at the proximal edge and go to town. I post-dilate most stuff between 20 and 24 atmospheres, and like, not a problem. Sometimes higher. Not worried about perforation because I know from the IVUS exactly what the vessel size is, precisely what the plaque composition is. I don't have to be worried about it. So this is what we did. Let's talk about unhealthy proximal landing zone. So this is fun now. Nobody likes these, right? And this is the same principle. So I won't, just in the interest of time, I won't belabor all of this, but you've identified all of the things that you need to identify by doing an IVUS. You know what the plaque composition is, so you'll treat that appropriately. That's a separate section of discussion based on the IVUS findings. We talked a little bit about it in the other room yesterday and today, which was about how to handle calcium, for example, and using what tool. Your distal edge is 3 millimeters, right, from EEL to EEL. Your lesion length is 30 millimeters. Your reference vessel landing zone is where your problem is. Because do you see proximally here, is this a healthy landing zone? Not so much, right? There's more than 30% plaque here. So now you're stuck a little bit, where you're going to have to stent lumen to lumen, plaque to plaque at this landing zone. An alternative is that you extend your stent further back to a normal landing zone. So let's say that that was the ostium of the LAD. Do you want to nail the ostium of the LAD where there's a bunch of plaque? Probably not. This is your classical case where you would cross over and come back into the left main into a normal landing zone. Or if, let's say, that was the left main, this is the one where you stent right back to the ostium and you hang a strut back. Because then you don't have to worry about proximal landing zones and 30% plaque versus EEL to EEL diameter, right? That is probably the one exception to the usual rule of lumen to lumen stenting in the setting of plaque. Because your proximal landing zone is what governs your inflow. You want that to be as big as you can. And so force yourself as much as you can to go normal to normal, okay? And then stent size selection. So if you got a stent size selection here, let's say that this is the mid-LAD, distal to mid-LAD, where you're not gonna go all the way back to the left main. What you want is a 3.0 millimeter landing zone distally, that's the healthy part, but you can only come up to 3.5 proximally. So as I said, find a better proximal landing zone. If you can't find one, pick a stent that goes from 3.5 to 4.5 and post-dilate the whole stent based on the EEL to EEL, but then leave one strut at the proximal edge and go ahead and post-dilate so that you don't dissect the proximal plaque. And then confirm that when you do the IVUS again, right? We do one pre and one post. The beauty of this approach is on your single IVUS, you get everything, all of the information you need, right? And that single information, that single run, allows you to ask for every balloon and every stent you'll need, and then allows you to do one post-run in the IVUS. So healthy landing zones will usually accept a 1-to-1 media to media true vessel size. Unhealthy landing zones require either the selection of a better landing zone or an extension of your stent to a normal landing zone so that you can really post-dilate. And when post-dilating heavy plaque burden, downsize just a touch or leave the proximal stent strut unpost-dilated. And just very quickly, I don't know why it skipped this one, but I'm going to give you just this two quick thoughts about this last one. Sometimes we get negative remodeling in the middle of the vessel, right? We've all seen that, right? And this is where the IVUS is absolutely critical. This is when perforations happen and where the intravascular imaging really tells you. Whether it's IVUS or OCT, doesn't matter. In the middle here, you have a 2.3 millimeter segment of vessel, but your distal is 2.5 and your proximal is 4. So this is the one where you have to overlap two stents. Because if you try to take one stent from 2.5 to 4, you're going to break the stent platform. And if you try to systematically post-dilate through the whole thing, you're going to break the stent platform, you're going to break the vessel. So take a 2.5 to a 3.5 stent in the distal edge, and then overlap that with a 3.5 stent that goes all the way up to the proximal. Do not try to post-dilate this to 5.25 millimeters here. That's where you've got an aneurysmal segment and you just deal. If you try to post-dilate there, that's where you get perforations. Okay? So the Pearls approach, which I'll throw up here in case anybody didn't get a picture of it and wants to take a picture of it. The Pearls approach is a simple, systematic way of taking a moment to understand what you're looking at on your IVUS and how you can then specifically use the information that the IVUS gives you to optimize your stent implant. Thanks very much for your time and attention.
Thank you, Dr. Kerala, for your excellent presentation. And as we are moving forward with our next presentation, our next speaker is Professor Dr. Mir Jamaluddin sir, who will be talking about how OCT differs from IVUS and which one is superior.
Good evening, respected chairpersons and learned audience. My topics is how OCT differs from IVUS, which one is superior. Sometimes OCT is superior and sometimes IVUS is superior. In most of the cases, IVUS is superior, except a few situations where OCT is essential. Let us see some important cases. This is a lady of 60 years, and her coronary angiogram shows left main with proximal LED disease with intermediate syntax score approximately 32. And IVUS pullback from LED to left main, and this is the result of IVUS on the left panel and on the right panel. Right panel is the ostium of the LED, that is 3.91, and on the left panel LM is 4.34. Shona jana? Achha. And this is after post dilatation, and it is on the left panel. It is, I see that apposed stent in the left main, as well as on the right the well apposed stent in the LED ostium, and this is pullback after the pre and post stent IVUS run LED to LM. On the left panel it is pre, and on the right panel is the post. It will take time, so I can go to the next. Stent has come. There is significant calcification on the left panel. This is the before procedure. And this is the final result after crossover stenting from LM to LED. And this is another patient, a young man, and having left main involving the ostium of the LED. And this is once again pull back from left main, LED to left main. Here it shows on the left panel, the left main is approximately 5.61, and on the right panel LED is 2.37. And this is after post dilatation and after stenting. On the left panel it is it showed 4. Probably it is not correct, as because LM we do not accept 4. 4 is less than 6 is not acceptable. And we see the pre and post stent IVUS run from LED to LM. On the right panel you see the apposition of the stent. It is well apposed. And this is the final result after angioplasty. This is another patient, LMC 99%, and involving the LED. And this is the pre-angioplasty left main and LED, and pull back from left LED to LM. This plaque burden, significant plaque burden, and this left circumflex, and significant plaque burden also in the left main. And this is after post stenting. And LM post stenting, this is pullback. This stent has come and it's well inflated. There is no under. and this is the final result after angioplasty. And this is another patient, Hamida Begum, having diabetic, hypertensive, chronic coronary syndrome, and angiogram, coronary angiogram shows triple vessel disease with intermediate syntax score. This is the coronary angiographic findings. And on the left panel and upper panel, right panel, you see there are 360-degree calcification. 360-degree calcification, and after pre-dilatation, after pre-IVL run, almost 360-degree calcification. And this is after IVL. In the upper panel, you see at 12 o'clock position, at 9 o'clock, 10 o'clock position, at 3 o'clock position, at 5 o'clock position. These are the fractures. These are the fractures. And pull back after post-IVL. Here you see the fractures. And the final result, this is the final result after IVL and deployment of the stent. And this is the OCT on the left panel. This is the OCT shown of a case, and we are showing it. Before stent deployment, this is another case. You see angio co-registration, the upper left panel showing the LED, and your dot, this dot, are you seeing this dot is coming proximally, meaning that you are coming from distal to proximal, and on the right panel, pullback of this OCT run. And longitudinal view in the lower panel, longitudinal view. And after stent deployment and the distal RCA, in the lower panel in longitudinal view is you see on the proximal part of the stent only 2-3 starts looks red, meaning that there is under, and it is approximately 300 micron, more than 300 micron. Post dilatation should be necessary in this case. After post dilatation, this is the scenario. Almost disappeared. 1-2 start is there with red. And this is another case, LCX, and this you see in the lower panel. Here also in the just in the proximal part, 2-3 starts which looks red, and on the right upper panel is pullback. Stent well inflated, but just at the proximal part there is some underinflation, and we shall have to post dilate it. And this is another RCA, right coronary artery proximal part, and right coronary artery proximal part in the lower panel you see almost there is 100% disappearance of the red, meaning that it is well inflated, there is no under. And now OCT is an optical analog of intravascular ultrasound, we know, and 10-fold higher resolution than IVAS, based on polarization properties and differentiate tissue characteristics, fibrous, calcified, lipid-rich plaque, and identify thin cap fibroatheroma. And this is one angiogram. It's a gold standard for coronary angiogram. It provides two-dimensional information similar to a simple road map. And why we need for more advanced imaging techniques? We need advanced imaging technique for 360-degree tomographic imaging and radiation, contrast exposure, angiographic angulation, vessel foreshortening, cardiac transplants, calcium volume, variability in lumen measurements, anatomical variation like left main disease, osteal disease, bifurcation disease. For left main disease and osteoaortic lesion, OCT is not superior. IVAS and OCT indications, established reference vessel size, both IVAS and OCT on the right panel you see, both are same, determine the lesion length, extent of disease, examine the post-PCI angiographic anomalies, and ambiguous angiography, left main on the right panel OCT is not superior and IVAS is superior, unusual lesion morphology is same. Acute coronary syndrome, plaque vulnerability, here there is superiority of the OCT over IVAS. And in most of the cases, IVAS, OCT, everything are class 2A indication. ACC recommendation is also class 2A indication. And contraindications to there is virtually no contraindication for OCT, but imaging, only contraindications to coronary angiography. If you cannot do coronary angiography, no question of imaging. And IVAS and OCT machine, both on the left panel and right panel, all of you know and have seen in our institute. And normal arterial wall, you see on the left panel, normal arterial wall by IVAS, and on the right panel, it is the normal arterial wall by OCT. And concentric mixed plaque, you see, these are the concentric mixed plaque by IVAS, and this is concentric mixed plaque by OCT. And eccentric fibrous plaque on the right panel, you see at the 3 o'clock position to 6 o'clock position, it is OCT picture. And calcific plaque, it is very important for OCT. In OCT, in 11 o'clock position, 9 to 11 o'clock position, you see left upper panel, there is thickness of the calcium, and which is shown in the left lower panel, how thick the concentration of the calcium is. That is only determined by this OCT, not by IVAS. And stent malposition, you see in the upper panel and in the lower panel, very nice, and nicely shown. This one on the right panel, stent malposition, it is far away from the wall. And in the lower panel, it is malposition in the IVAS. Interluminal thrombus. Here there is one superiority of the interluminal thrombus detection. By OCT, we can detect the red thrombus as well as white thrombus, but by IVAS, we can't differentiate. And intracoronary imaging showing the dissection, false lumen and true lumen. You see this one is the false lumen. Lower panel, this is by OCT, and this is by IVAS. These are the several parameters, total vessel area, lumen area. These are the theoretical things you should have to know. Wall area and percentage of plaque area, indices of eccentricity. Optimal stent expansion, we should have to know what is optimal expansion. Optimal stent expansion defined by in a stent minimal luminal area more than 90% of the average reference luminal area, or equal to or more than 100% of the luminal area in the reference segment with the lowest lumen area. And difference between IVAS and OCT, tissue penetration, OCT tissue penetration is less, in IVAS tissue penetration is more. And technology, OCT is near infrared and IVAS is ultrasound, and imaging speed pull back 20 millimeter per second OCT and 1 millimeter per second IVAS. And catheter size, OCT and IVAS almost same, 3.2 French and 3.5 French, and blood removal with contrast is essential for OCT, but it is not essential in IVAS, and that is the reason when there is the renal function is impaired. OCT, we usually do not like OCT, we usually like IVAS, and there is superiority of the IVAS over OCT in CKD patients. And you see the tissue type, fiber, calcium, lipid, red thrombus, white thrombus. In OCT, we can see particularly in calcium, it has sharp edges, low reflectivity, low attenuation. And in IVAS, very high reflectivity and shadowing, meaning that behind the calcium there will be dark. And lipid, diffuse edge, high reflectivity, high attenuation. These two are very important. If it is calcium, low reflectivity, low attenuation, and if it is lipid, high reflectivity with high attenuation. Evidence of superiority, intravascular ultrasound versus optical coherence tomography for coronary artery imaging, apples and oranges. Result, the development OCT has markedly improved intracoronary image resolution compared with IVAS. OCT is superior to IVAS in a number of aspects, particularly distinguishing thrombus formation, coronary dissection, and incomplete stent apposition following implantation. And another study, when to use intravascular ultrasound or optical coherence tomography during percutaneous coronary intervention. IVAS is superior in the diagnosis and management of patients with LMCA disease, renal dysfunction, aortocoronary ostial lesion, and CTO. And OCT is superior to IVAS in assessing the etiology of stent failure, calcific coronary disease, and Minoga. OCT guided PCI versus angiography, there are several studies. All these studies shows that OCT guided angiographic study is superior than only angiography. And optical coherence tomography versus intravascular ultrasound versus angiography once again. Optical coherence tomography provides better intracoronary visualization compared with intravascular ultrasound due to 10 times better resolution. And OCT has less tissue penetration than IVAS and is unable to visualize the entire vessel wall, especially at the diseased segment. And we hope this will be achieved based on the result of Illumina 4 and optical coherence tomography, optimized bifurcation, event reduction, and improve the impact of revascularization outcomes of intravascular ultrasound guided treatment of complex lesions. These two studies are ongoing. By these two studies, we shall be able to further tell which one is better. And so, in order for patients to benefit from either IVAS or OCT guided stent implantation, it is necessary for the interventional cardiologist to be able to fulfill three basic requirements: proper image acquisition, accurate image interpretation, which requires that images be acquired properly, and correct decision making based on accurate image interpretation. OCT more resolution, less penetration, and IVAS less resolution, more penetration. The question of IVAS versus OCT is wrong, and in fact belies the true conundrum, and resolution and surface retail favoring OCT, media to media sizing favoring IVAS, fine details favoring OCT, the bulk of clinical data favoring IVAS. So, the question of superiority is still a question. Both modalities has got significant impact on coronary intervention. Thank you. Thank you for.
Thank you, Professor Mir Jamaluddin, for the informative speech. As due to time constraint, we are moving to our next speaker. Question and answer session will be the end of the all speakers. So may I now request Dr. Ajoy Dotto for the presentation on role of cardiac MRI in ischemic heart disease, decision making in revascularization.
Good afternoon, respected chairpersons and panelists, dear audience. Actually, we are now going to present role of CMR in ischemic heart disease in decision making. Actually, when a patient comes to us with chest pain, what as a physician we want to know? Is this chest pain is really due to ischemia? And if we find this is a ischemia, then which vascular territory is involved? And if we are able to specify the vascular territory, then we want to know the area supplied this vessel, is it viable? And next, if it is not ischemic heart disease, which causes chest pain? Let's see a patient, a 65-year-old female, hypertensive diabetes, present to us with chest pain on exertion, resting ECG normal, echo normal. If we put the data in Diamond-Forrester table, which shows the pre-test probability of obstructive coronary disease, and it is around 16% probability of obstructive coronary disease. So next, which test will proceed? Invasive or non-invasive? Actually, according to the 2021 chest pain ECG guideline, actually if you see the intermediate to high probability of case, there is two modalities of class 1 indication. One is CCTA, I mean CT coronary angiogram. Another is stress test. So next see how accurate the diagnostic non-invasive modalities now. Most of us actually we do exercise ECG, but look at the sensitivity of this study, around 50%. Actually, when a patient suffering from stenosis, if it is non-LAD, it is less than 50%, and when it is LAD stenosis, it is 60 to 70%. But if you look at the accuracy of coronary CT, it is around 95 to 99%. I mean, its negative predictive value almost 100%. When CT angiogram told that there is no obstructive coronary artery disease, it is 99% negative predictive value. And if you look at the vasodilator test MRI, it is around 80 to 90%. So detection of ischemia, today I will present about role of stress CMR. And the stress CMR as class 1 indication, and obviously exercise ECG now guideline in 2A indication. So in CMR, we use two modalities. First of all, first pass perfusion, and second, is there any inducible wall motion abnormality like dobutamine stress echo? So who are the candidates for stress CMR? Actually, chest pain with intermediate to high probability CAD, or known CAD of indeterminate stenosis, some patients of HCM who present with atypical chest pain to see whether there is any microvascular disease, and some patients, especially female diabetic patient, who repeatedly come to us with chest pain, CAG normal, but there is chest pain. I mean, ischemia with no obstructive coronary artery disease. We all know the ischemic cascade. Actually, when a patient comes to us chest pain, it is the ultimate manifestation of ischemic heart disease. Before the appearance of chest pain, there are so many events occur which we can identify early. First of all, there is perfusion abnormality. This can be detected by nuclear study like SPECT or cardiac MRI by stress CMR vasodilator test. And CMR can also detect regional wall motion abnormality and even ultimate the infarction by scar detection. So what is the principles of perfusion image? Look at the left panel. When there is significant stenosis of a coronary artery, there is reduced flow in the artery, and ultimately there is auto-regulation at the level of microcirculation, which causes blood flow to ischemic myocardium, which is equal to healthy myocardial vessels. And this is occur as a auto-regulation. But when we stress, even we exercise or pharmacological stress, most commonly use adenosine or in different countries dipyridamole, there is interesting phenomena occur. In healthy microvessel, there is dilatation, causing shunt of blood from the disease area, which is supplied from the collateral vessel. So there is blood flow to the normal area increased, and blood flow to the stenosed vessel area is reduced. So there is heterogeneity of myocardial blood flow. This is the key technique to detect the perfusion abnormalities. Now we can detect the ischemia. So which vascular territory is involved? As for AHA 17 segment model, we can assess LAD territory by anterior and septal area, inferior and infraseptal by RCA, and lateral area by LCX. Depends on the dominancy of the circulation. Let's see how perfusion study, CMR perfusion study here. So above panel showing the stress study and lower panel showing the rest study. Look at the above panel. There is hyperperfusion. Look at in the inferior, basal inferior, and mid-inferior wall, and apical inferior wall. And in rest condition, there is no perfusion defect. So it is indicative of inferior ischemia as evidenced by the stress test. There is RCA territory ischemia. Another case showing the anterior wall, septum, and inferior wall showing the perfusion defect as evidenced by the black line. And in rest condition, there is no perfusion defect. There are another modalities we can use to see the inducible ischemia, like dobutamine stress echo. So stress perfusion MRI, we use 3 types of information: functional image, delayed enhancement image, and perfusion image. In stress MRI, if the stress perfusion image is positive, I mean, in that area as a black subendocardial perfusion defect, and in rest image there is no perfusion defect, and there is no scar, so this is the stress-induced ischemia. But if the stress is positive, rest is positive, and LG, I mean scar is there, so this is the scar-related perfusion defect. But if the perfusion defect extends beyond the scar area, there is peri-infrared ischemia. And there are lots of evidence showing the first-pass perfusion by CMR is superior to SPECT. By importance landmark study, MR impact CMR1 and CMR2. This is a correlation of CAP and CMR study. Here is LED showing more than 95% lesion in the proximal, and corresponding the anterior wall, septum, and inferior wall showing perfusion defect. But there is no scar as there is no history of MI. So there is significant inducible ischemia in the LED territory. Case 1, 60 years male non-STMI, anterior wall hypokinesia, 50% of stenosis, ejection for 50% triple vessel disease. Our clinical question was which vascular territory are ischemic? Above the functional image showing the no wall motion abnormality, but in lower panel LG showing there is scar in the subendocardial area. So this is the subendocardial infarct, but there is no wall motion abnormality. Perfusion study showing that basal lateral and mid anterior and inferior wall showing significant ischemia. So there is significant triple vessel disease. Another case, 60 years of male, triple vessel disease showing RCA 100%, LED 90%, LCX 60%, OM1 80%. First of all, functional image showing the septal area is hypokinetic, and corresponding LG showing subendocardial infarct in the both basal, mid, and apical. And perfusion defect showing there is a perfusion defect in the basal inferior, anterior, septal, and inferior wall. But rest imaging, there is no perfusion defect. So there is peri-infrared ischemia in this case. Another entity, Inoka, 58 years female with atypical chest pain, showing the stress study, there is circumferential subendocardial perfusion defect, both basal, mid, and apical, but there is no LG, I mean no infarct. Coronary CTA showing LED 30%, RCA 30%, I mean non-significant obstructive coronary disease. So we can detect subendocardial ischemia by MRI. Viability, we know when a vessel is occluded, within 3 hours, 80% of the myocardium is damaged. After that, 20 to 10% remain for 24 hours. And now we are physician, we try to salvage the myocardium within early time. And it is found that within 20 minutes after occlusion, there is reversible transmural injury. But within 60 minutes, less than 25% area is irreversibly damaged. And within 3 hours, around 50 to 75% damaged. And after 3 to 6 hours, actually more than 75% damaged. And it is found in different studies showing that if there is no infarct and there is LV dysfunction, there is chance of recovery about 80%, whether if there is transmural infarct more than 75%, there is little or no chance of recovery. So in 50 to 75%, there is a borderline. In that case, we look at the wall motion abnormality. If the wall motion is akinetic, there is no chance of viability, but it is hypokinetic, there is a chance of viability in range of 50 to 75%. So in a patient with infarct, if the wall motion is normal, there is no issue of viability, which is found in non-STMI patient. So a dysfunctional myocardium area is considered viable if the regional dysfunction significantly improves after revascularization by at least 1 point from akinesis to hypokinesis or from hypokinesis to normal. This is regional viability. This is more important selection of infarct-related artery revascularization. But when the overall EF significantly improves more than 50%, it is global viability. This is commonly found in chronic ischemic dysfunction, where the 70% of patients with chronic ischemic LV dysfunction have significant improvement in LV function after revascularization, which is found in 81% in STITCH trial. So what are the goals of viability assessment? Identification of patients that would benefit from revascularization, prediction of recovery of regional or global LV function after revascularization, and an advanced congestive heart failure, it helps to take decision making whether revascularization versus left ventricular assist device or transplantation will consider. And there is evidence showing that in a patient with viable myocardium, revascularization was associated with 80% mortality reduction annually compared with medical treatment. But in a patient without viability, mortality was not improved by revascularization. So there are so many tests in front of us, which test we'll take. And it is found that the resolution of MRI is far better, around 20 times better than SPECT. This is a histology showing the subendocardial infarct. We showed in the CMR there's subendocardial infarct in white area, but SPECT missed this subendocardial infarct. But transmural infarct SPECT can detect, but small subendocardial infarct SPECT invariably missed. Like echo, we compare the wall thickness in end-diastole, wall motion, and there is the key findings of MRI is delayed enhancement images. After gadolinium contrast, we inject, and after 10 minutes, we take the picture showing whether any scar, infarction, or infiltration, this area will white. So this is the normal wall motion seen in MRI, and this is the inferior wall hypokinesia in the basal, mid, and apical wall showing in the MRI. So principles of viability imaging is all infarcts enhance. Actually, after MI, from day one, all infarcts remains white, and it's live for lifelong. And all non-enhancing myocardium is potentially viable. There's a case of 65 years male, OMI inferior 45%, CAG, LCX 90%, LED 80% stenosis. Clinical question, is there viability of LCX in LED territory? These are two-chamber view like echo, and four-chamber view showing the inferior wall is hypokinetic. And this is short axis view showing inferior wall from basal, mid, and apical area is akinetic. And corresponding segment showing the white transmural thickness of the LCX territory. So whether the stenosis of the LCX, it is not viable. So this is another case showing global hypokinesia, but their wall thickness is preserved. And if you look at the wall motion, the whole global myocardium is hypokinetic, particularly anteroseptal, basal anterolateral wall is transmural thickness, infarction showing akinesia. And this case is triple vessel disease, and all the vessels are ischemic and producing hibernation. So in this case, revascularization is worthy. So strength of CMR is to detect the dead tissue imaging. LG is excellent for sensitivity and negative predictive value. And for contractile reserve imaging, it has excellent specificity and positive predictive value. Beyond viability, it also shown the thrombus, apical thrombus, and large aneurysm in the inferior wall. And there is microvascular occlusion in the inferior wall, which is the poor prognostic factor for revascularization, and also ischemic MR in the right lower panel. So take-home message, CMR is a comprehensive one-stop test, and not only detects the ischemia, it also gives the immense information about the viability and other prognostic factors like LV volume, RV volume, ejection fraction, microvascular occlusion, even intramicrobial hemorrhage, thrombus, aneurysm, which are the prognostic factors we should consider for the decision making for planning of revascularization. Thank you for patience hearing.
Thank you, Dr. Ajoy is present now. He is doing good work, the CTMR in Sylhet, and he is trying to develop this CTMR in Bangladesh. I have a query. Most of the CTMR reported by the radiologist. So, in my experience, there are some discrepancy between the report and angiogram. Is frequently seen. What is your comment?
Being a cardiologist, I personally feel that if we do not have sound knowledge of cardiology, basically clinical knowledge and echocardiography, it is very difficult to develop skill in advanced cardiac imaging. And that is the lackings. Actually, radiologists, they take the snapshot. They do not talk the patient, take the history, do not correlate with the other findings. And they just see the on workstation the report. That's why they miss many things. But in India, around 80% of advanced cardiac imagers are radiologists, because cardiologists are not interested to do lots of time in the place. But Europe and America, 80 to 90% physicians are advanced imager are cardiologists. I think this is new, but hot topic in the world now. So the new generation should come up, and there is very interesting things, and you can correlate everything. Thank you.
Thank you, Dr. Ajoy, for your nice presentation. Actually, you are helping the interventionalist working in Sylhet region by, so we can select the patients who will likely to benefit from intervention. So I have a question for you regarding after an acute coronary syndrome, how much time interval we need to give the patient for a MRI scanning to differentiate between a stunned and a hibernating myocardium? How much interval it is required? And number two, in what situations you use the contrast medium like the gadolinium to delineate the affected myocardium more precisely?
Thank you, sir, for nice and relevant question. Actually, acute MI is an inflammatory process, and that's why myocardium is inflamed. And MRI has the ability to detect the inflamed myocardium, as evidenced by the white area. And this inflammation actually 6 to 8 weeks takes to dissolve. Otherwise, if you do prematurely LGE, it overestimates the infarct area. That's why we usually 4 to 6 weeks wait for resolve the inflammation and take the gadolinium enhanced images. And actually, we use gadolinium 0.1 to 2 ml per kg body weight, and this is not nephrotoxic, and it is even used even GFR up to 30. Sorry.
Thank you, Dr. Dotto. We will be back to our presentation. Professor Smita Ahmed, sir, please.
Thank you, Dr. Ajay Dotto. Now to have a presentation on modalities of non-invasive tests for myocardial revascularization, I would like to request Professor Chaudhry Meshkat Ahmed.
My respected chairperson, especially Madam, Fazila Madam, and the distinct interventionalists of the country. The job of a cardiac ultrasound sonologist is very simple, is to find out the inducible myocardial ischemia. If a patient do have inducible myocardial ischemia, this patient is going to get benefit with revascularization. It is a simple job, but at the times we need to know about the viability. And in more recent days, since we have CT angiogram along with non-invasive FFR, so the anatomical imaging along with the functional imaging gives the alternative evidence of myocardial ischemia. So we have all these modalities. We have the stress ECG known as ETT, the stress echocardiography, SPECT, PET, MRI. And as I have said, the equally important the tool, non-invasive tool nowadays is CT angiogram. So as I said, I will be dealing with my case. My first case was 64 years old male. He had an attack of myocardial infarction. We selected to do an abdominal stress echo in our laboratory. If you look at the images from resting images to low dose images and to the peak dose, you will be able to find out that there is biphasic response. There was motion in the low dose, and it again become hyperkinetic at the peak dose. We call it biphasic response. When dobutamine stress echo shows a biphasic response, it has got very high sensitivity and specificity of the fact that this patient is going to get benefit from revascularization. Even we do not need to know how much scar is there in the myocardial tissue, because if the patient do have amount of scar in the myocardial portion is more than 50%, the dobutamine stress echo will not be positive. So we have to also consider to this image that if we do perfusion imaging, perfusion imaging is capable of showing the ischemic zone and viable zone, but it does not allow us to know fully about the extent of scar. For a patient with myocardial infarction, if we really can bring some meaning to their life, there has to be viable myocardium of more than 50%, which again cannot be that much assessed by nuclear imaging. So the ultimate frontier for a patient with myocardial infarction is, as Arju has said, the MRI. Our second case was a lady who was referred to us for preoperative assessment while undergoing non-cardiac surgery. And as you can see in this, in the resting echo, the patient was having global hyperkinesia. Actually, these are the cases that we meet in our day-to-day life. These are the patients sometimes we call them as ischemic cardiomyopathy. They are having heart failure, and we really do not know whether revascularization will give any benefit to them. So again, for this patient, we arranged a dobutamine stress echo, and as I said, my images are not that great, but you'll be able to find out there was gradual increment of the motion. When dobutamine stress echo was given, even in this picture, if you look at the final peak image, you will find, and if you compare it from the resting image, that there was gradual incremental motion. We call it monophasic response. Actually, we were dealing with a case of stunning myocardium. We are not dealing with ischemic myocardium. It was not ischemic myocardium, it was stunning myocardium that showed the hyperkinesia. So for this patient, revascularization will not give any benefit. So our third case, she was a patient who was admitted in one of the hospital, one of the government hospital in Dhaka. This patient had anterior myocardial infarction. She underwent coronary angiogram. There was significant LED lesion, but the PCI at that time was deferred because this patient was having huge thrombus burden in the left anterior descending artery. For his financial constraint, he got admitted in our hospital. We also planned to have an angioplasty done for her, but in the meantime, we decided to see whether there was any viable portion of myocardium in LED territory. So again, we did dobutamine stress echo in this patient, and if you look at the LED territory, it was akinetic in the rest, and the echinacea shear did not improve even with maximum stress. We can see rest of the LV segment was moving so smartly, but the LED territory were still akinetic. So for this patient, we thought that in some cases when we when we find echinacea in the dobutamine stress echo, the final frontier is MRI, or the other frontier could be positron emission tomography. So we had MRI facilities in one of the private diagnostic center where one of our colleague works. So you can see in this in this MRI image that there was some motion in the LED territory. So it was not akinetic as we found in the dobutamine stress echo. But as we moved on in left gadolinium scanning, you can see this is normal thickness of the normal myocardium. And if you compare this with the scar tissue here, you can find that more than 50%, about 70% of scar tissue was there in that patient. So had this patient not thrombus in the LED on the first instance when she underwent coronary angiogram, she would have an PCI done. So please remember, when you are dealing with a patient with all myocardial infarction, please look at the portion of the viable myocardium. All these cases that I'm showing here are being collected from here, from Bangladesh. So now time has come when we can make some justice to our patient. So my request to my interventional cardiologist to become little gracious. So this is the basic principle. When we have biphasic response, we call it hibernating myocardium. These are the myocardium that is going to get maximum benefit from revascularization. When we have monophasic response, this is stunning myocardium. By no means revascularization is going to help this patient. And when we do have no response, possibly this is dead myocardium, non-viable myocardium. So if we we have PET facilities in Bangladesh. Some of our nuclear guys are doing this, and they're doing some nice job. And if you find this this variation in the images, then you'll be able to find out the differentiation between the viable stunning and the non-viable portion. The important thing that has to be noted in this image is, if you look at the perfusion image in this case, had this patient underwent SPECT only, we would have missed the viable portion. So dobutamine stress and SPECT at a times can detect non-viable portion which becomes viable with MRI or PET. So there may be some use of PET and MRI in some patients, not all the patients. In majority of the cases, you can solve your cases into the dobutamine stress laboratory. Even in your normal echo or in normal ECG, that can give you clue that this patient is going to get benefit from revascularization. So this is my fourth case. This is the case that we really encounter in our day-to-day life. And with the advent of troponin, so-called high-sensitive troponin, possibly you all get more and more cases of non-STMI. Non-STMI has become so prevalent nowadays. So, and again, among these non-STMI, we know some of them, if we do the GRACE score and they belong into the high risk and the intermediate risk, we put them into cath lab and do the intervention. But there are patients who do not have chest pain, who don't have changes in the ST segments, and their troponin are not that high. They're low risk non-ST SCS patients. They can go for some form of imaging, some form of stress test. And as we can see in this slide, the ESC guideline for imaging +1 is stress imaging, and alternative to this is CT angiogram. So for this patient, we did stress imaging. We had stress echo in our lab, bicycle bicycle stress echo. And the finding of this stress echo was the patient showed no evidence of inducible ischemia. And if you look at the peak dose, the heart is contracting so smartly, and you can easily make a conclusion that this patient was having no inducible myocardial ischemia. So the test that we are doing in our laboratory, the bicycle ergometer, which is superior than the SPECT, and we are used to with echocardiography. So it is our skill in echocardiography that prompted us to refer our patient to the SPECT. Had this patient could go to the PET, that could be little superior. Or if the patient would have CT scan, CT angiogram along with FFR, that would have been better. But right at this moment, we are satisfied with doing the bicycle stress echo, which yields at least 80 to 85% sensitivity, much closer to that of MRI or PET. So this is our final case. Again, a patient with stable angina. The case that we meet in our chamber, in our practice. This pretest probability is little older, but I'm fond of this probability picture because it gives me so many information. The probability that falls into the region of light red of the patient who should undergo relatively better imaging tests like PET or CT angiogram, but we are happy with doing the bicycle or the treadmill echocardiography. So this patient, my patient, he was 60 years old, retired professor, was having angina during walking. We were little concerned about his probability score. It could be anywhere between 84 to 68. So we were little concerned about this patient, and we decided to, again for this sort of patient, the recommendation, class 1 recommendation by ASC is stress imaging of CT. So we went for treadmill echocardiography for this patient. Again, the image is not that great, but surely you will be able to find out the motion is normal at the peak exercise. So what we got from this patient, we got the result of the treadmill. The patient had a good functional capacity. He didn't have any ST segment depression during walking in the treadmill. And at the same time, on the echocardiography, we found very smart wall motion. So if you look at this chart, which is integrating the wall motion score and the ST segment score all together, and if you really assess the risk for my patient, he's a retired professor of surgery, I was confident that I have given him a good suggestion that he should maintain a lifestyle modification, a risk factor modification, and he will do well. Again, having saying that, I would have done better if I could do a stress PET for this patient, or if we had CT angiogram with FFR. So our post-treadmill exercise is as good as bicycle ergometer, and in a lot of our center we do have the treadmill and the echo side by side, and we can do this test regularly. So that's all. Thank you very much for the patient hearing.
Thank you, sir, for your excellent presentation. IVAS, OCT, and the other imaging modalities have definitely given us new perspective in treating the patient with cardiac patients. This session, we have learned about these all modalities. As we have very little time, so we go to the panelists and chairperson for their brief comments. First up, Dr. Pradip Kumar Karmakar, sir.
Thank you, Meshkar sir, for your nice presentation. Your data and presentation is supported by our MI patient, the O-trial, occluded artery trial, that any post-MI patient, if it not primary PCR not done in timely fashion, then if it is 100% occlusion, the artery should not be revascularized. It is a great trial in the occipital artery trial. And even in the CCS cases, chronic coronary syndrome cases, the CARS trial, you supported this trial. And another thing, important thing, PCI do not improve survival, do not have the survival benefit except the left main and the LAD ostium. So we should follow the guideline, then we will optimize our treatment revascularization policy. Thank you, sir, for a nice presentation.
Thank you, Pradip Kumar, sir. Now I request Dr. Kamal Pasha to say a few words regarding these presentations.
Okay. Because of the time constraint, I just want to congratulate all the speakers for their brilliant presentations, and thank you all.
Thank you, Dr. Kamal Pasha. Now, Dr. Salauddin Ulubbi, sir, would you please say a few words?
Thank you, all our teachers. We learned a lot from them, from this learning session. And thanks all. Thank you.
Okay. Thank you, Dr. Salauddin Ulubbi. Now, the final comments from our respected Professor Fazila-Tun-Nesa Malik, madam.
So this was a very important session, I feel, and I'm so privileged that I was here. And today, actually, I learned a lot from both from Ajay as well as from Meshkat sir. Great presentation, but the thing is we need to talk more about this, about when to revascularize, why do we revascularize, and is there any justification? And for this, we need to have these modalities widely available and also need to make our younger cardiologists aware of this. So thank you for two great presentations. The other two were with invasive cardiology. Those were also great as well. I missed the first, but Mir Jamal was great, but this was a wonderful session, and I'm glad that I was a part of it. Thank you.
Thank you, madam. We are near to end. Just before end, we are requesting our respected speakers, please do come over the stage and take the memento from our chairperson and panelists. First, I would like to request Dr. Ajay Dotto. Dr. Ajay Dotto is taking the memento from Dr. Salauddin Ulubbi. To Professor Chaudhry Meshkat Ahmed, requesting Professor Fazila Malik to hand over the memento. Thank you all. We had a great session. Now moving to our next session.